Well, if you look at the patient access API, and if you look at the 0057 regulation, what's it really doing? And what you have there is patient access API is really that core of data. Provider access is more or less using that same data to a different audience. So it's going to the providers. Payer-to-payer is where a member has opted in, they've joined the plan. Now the plan, if they opt in, can get that information. So rather than wait until they turn up in an emergency room and you're dealing with a high-cost claim, they could actually take a look at the history of claims, any of the clinical data that's come across for the last 5 years, and work out, I need to put this member onto a particular preventative program so that you try and avoid that. You're not waiting for those high-cost claims to then drive a change in the way that you manage the member. So all of that really builds on the patient access API. But the big misconception, I think, is that we think that prior auth is request comes in from a provider, the plan answers, gives the result back. But anything beyond a really small plan, and you go talk to those payers and they'll say, I've got half a dozen vendors. And in many cases, we're lucky if they've only got half a dozen vendors. So you're then trying to stitch together a whole series of different vendors to be able to give that answer. And the question is going to be, are all of those vendors going to be ready? Are they just going to turn around and say, no, I'm going to stick with X12 and do the transactions that way? Or are they going to buy into FHIR, which will allow you to then do more computable work on the information? FHIR is much better suited to that. So it's going to be interesting in how payers can effectively stitch together the behind the scenes work that needs to get done.